Thank you.
Thank you, Senator.
Thank you very much.
Thank you very much. And our next speaker is Senator Marty Golden.
Thank you, Madam Chair. I'm just going to go over some of the, real quickly, some of the comments that have been brought up. One was the long-term care policies that have been abused by the industry over the last year or so. And if you look at spousal refusal, and you look at long-term care, what we're doing is we're forcing our seniors into the best insurance plan in the nation. It's called Medicaid, and it shouldn't be happening. These are people trying to do the right thing, and unfortunately, they're not being allowed to do the right thing. 500,000 policies, 100,000 of those policies have gone up more than 50% in the last year and a half. Think about that. It's absurd. Why would anybody want to buy a long-term care policy in the state of New York? Why would somebody want to do the right thing? This is more of a DFS issue than it's your issue, but you do belong with DFS right now in trying to correct this imbalance so that we do have people doing the right thing here in the state of New York. It's more of a comment than a question. Going back to some of my colleagues with the specialty drugs, there is no such thing. We allowed the PBM to come in and make up the specialty list, and that pharmacist that's in the pharmacy, that's at the PBM, that's at the mail order, has the same degree, knows what drugs he or she can handle or can't handle, and knows the pricing structure. And if they can match the pricing structure, they should be allowed to participate. So we need to reduce the terms and conditions to a modest number that all pharmacists, whether they be local pharmacists or they be our large pharmacists or they be PBMs or they be the mail orders, that they have the same terms and conditions. If you want to comment on that, you can. I believe it's arbitrary. Again, it's just a statement, but if you want to comment, you're welcome to. Okay. Another comment. The Medicaid, the New York City, it's $180 million, I believe, and it's over this year coming up. But by 2020, it's up to $735 million, and that's just one issue in the city of New York. CUNY, you look at the list goes on. So I would imagine that if the city of New York were in the tax cap, like the rest of the state of New York, this could not happen. And the billions that are going to be clawed back by the state would actually be going back to the taxpayers in the city of New York. Am I reading that correctly?
Under the proposal, the city's budget contribution would increase, and that would offset the state of New York's contribution to the program.
But if they were part of the tax cap and they would have the same commitments that the rest of the state has, except for those 5 counties in the city of New York, they would have the same as the other counties. Am I correct?
The city of New York is exempt from the property tax cap. It's
Today.
the only jurisdiction that is exempt.
Today.
Correct.
But if that were to change, that could not possibly, you could not get this outrageous clawback. This is an outrageous clawback that should be going back to the taxpayers, not to the state of New York. This is something that should be part of a tax cap that should be statewide, and that we should be the same share as the rest of the state. Yes? No? Thank you. You guys are great. keep up the good work. The lack of funding in our life science research and biotechnology. Our major competitors, that being Texas, California, Massachusetts, as we see at IBM, we see a whole host of companies and people that are being attracted and taken out of the state and brought into these other states. We need to do something about that, whether it's a biotech or biomed incentives or researchers, grants. We didn't see that in this year's budget. we're looking at talking to my colleagues and trying to do and work with our colleagues to put it into our one House bill to try to get some money to keep our researchers. See, when you lose a researcher, you lose a team. When you lose that team, you lose the ability to be able to discover the next life-saving drug that could actually be a plus for this great state, and being able to manufacture that drug here and create the jobs and opportunities that we need. Is there a reason we left that out, or is that an oversight? Or?
Well, I will mention that there is money put into a venture capital fund for research, part of the breast cancer initiative the governor has proposed. So that's one area. There's also efforts being made. We have the Genome Institute, Genome Center here in New York, which looks at as many of the challenges in genetics and proteomics. In addition to that, there is downstate, I'm not necessarily saying about the budget, but in general, there is a lot of areas of research that are going on in the state of New York. We have some of the best scientists in the nation, and we are moving forward with some of the...
Texas and California and Massachusetts are eating our lunch, and so is Canada and other countries around the world. And it's only because we don't put the incentives forward to be able to hold these people here, to hold these companies here, and to give the incentives to these researchers and for biotech and biomed that we are losing a great opportunity.
Well, as one who's a big supporter of research and recognize the benefits that will come with research, I hear your...
I'm glad you agree, sir. Now, getting back to hospitals. The area that is ground zero for the state of New York, maybe even for the nation, is Brooklyn. Some may disagree with that, but I doubt it. Brooklyn, 2.5 million people, the healthcare system is a disaster in certain parts of that great county. We do see different things happening, which are very, very good, very positive. We see NYU taking over Lutheran, NYU involved with Long Island College. We see North Shore involved with Maimonides. We see great things happening in Brooklyn South, not such great things happening in Brooklyn North. Senator Hannan did point out the capital monies that are being distributed, $3-point-something billion. I know none of that money has gone to Brooklyn yet, because I do know you're looking at Brookdale, because something has to be done with Brookdale. Interfaith and some of the other hospitals that are in Brooklyn North have to be right-sized and have to be profitable, and there's a lot of work going into that. I'd like to know what work is going into that in those right-sizing of those hospitals. And the last part of that question is going to be about downstate being possibly sold off to another healthcare system. And if you could comment on both of those.
Sure. Thank you for the question about Brooklyn. Let me say a couple things about Brooklyn, because we've been looking at this for a while.
I'm listening.
Brooklyn, with its 2.7 million people, if it were a city, it would be the 4th largest city in the nation. And no one should have to leave Brooklyn, if they don't want to, for a high-quality, state-of-the-art medical care. And I know that they do, because having worked in the Bronx and in Manhattan in medicine for many years, I saw on those charts that they were coming from Brooklyn. What we have been doing is looking at doing our due diligence, looking at the challenges, both the financial challenges in the hospital and the challenges in general in that community, to get a framework to figure out how we move forward. What are the next steps?
Is there a schedule for that?
Right,
Is there a timeline for that? Go ahead.
Yeah, so we have just finished a lot of that work, and a lot of people have been involved in diligently trying to get the information to do the homework.
Can we have another roundtable with Senator Hannan, please, on this issue?
And I, within the coming month, would very much welcome the opportunity to sit down with the members of the legislature who are focused on this area, and to get your input and concerns, but not just also with the legislature, but we also at some point need to reach out to the community and the people who are living in Brooklyn, who, well, obviously legislators who are there do, but others who are accessing that care, to figure out how we move this forward, because this is a system now meaning in the next month. And it's a system change. And I actually believe that when we are done and when we have developed the framework and have put into place the system for Brooklyn, it will be a model for urban health care for
the nation.
for not only New York, but for the nation. I agree that this will be a model for healthcare.
Downstate's not being
So
sold?
Downstate Medical School is a medical school that has generated more doctors for this state than I believe any of the other medical schools in the state. And we are working with Downstate, and we need to strengthen the medical school there.
It's a great, great place, and it does great work, and it's an essential part of Brooklyn. It is full. Kings County is full. We need to keep that place open and operating.
That
Last
medical
question.
school has put out some of the leaders in medicine.
One in
and
three doctors come from, or 1 in 3 doctors come from downstate in the state of New York. Medicaid Part C cost sharing. Doctors are complaining about the Medicare Part B cost sharing that we did in the last year's budget that was proposed last year and rejected. This would reduce the amounts that would be paid for dual eligibles, Medicaid, Medicare eligible for our audience, to the amount that the Medicaid pays, even if Medicare pays more. Why?
I mean, at the end of the day, the proposal is that for the service for a dually eligible individual versus the service that we would pay for somebody who's just on the Medicaid program, that the state should basically pay the same amount for those type of services.
But if Medicare pays more, wouldn't we want to take the money from Medicare versus Medicaid?
But the issue is that that's why it generates savings, the proposal, because when we pay more, the taxpayer pays more. And so what we're suggesting is to adjust for those Medicare Part C crossover payments to ensure that we don't pay more than what Medicaid would pay.
So you're suggesting that we're paying more in Medicaid versus what Medicare pays us?
No, I'm saying is that we are, in certain circumstances, paying the net reimbursement the provider's receiving is greater than what Medicaid would have paid for that service for a Medicaid-only member. So what we're saying is that we want to cap our total cost, the Medicaid cost, at what Medicaid would otherwise have paid for the service.
Could you get Senator Hannan and this body a copy of those numbers, please?
Absolutely.
Thank you very much.
Thank you. We've been joined by Assemblyman Abenanti, and next to question, Assemblyman Gabarino.
Thank you, Chairman. Assemblymember McDonald asked some questions before, but I couldn't really hear some of the answers, so I'm going to just follow up. Part of the Medicaid redesign team has, under the budget, has $65 million in pharmacy savings. There was a ceiling on blockbuster drugs, brand name blockbuster drugs. Do you have an idea of what some of these blockbuster drugs are that you're going to be putting the ceiling on?
Sure. So it's been some publicity around in the recent, I'd say last year to year and a half, there have been a number of drugs that have come to the market that have been priced, and these are brand name medications new to the market, priced in ways that have been seen by many, including ourselves, as very problematic. So the sort of poster child for this has been the hepatitis C agents, where you're talking about for drugs such as Sovaldi, costs for the treatment of an individual ranging at about $85,000 for one set of treatment, a number of weeks. Now the potential benefit of Sovaldi and these new treatments for hepatitis C are potentially tremendous in the sense that whereas the side effect profile for previous treatment regimes for hepatitis C were so problematic that it was very difficult for patients to actually go through that treatment, and the new drugs offer a tremendous amount of promise. But the concern is that these new drugs are priced in ways that make it extremely difficult for payers, not just Medicaid, but any payer, to be able to maybe make them as accessible as one would like. So what this proposal, and that hepatitis C is just one, but you could look at some of the new high cholesterol medications. You could look at some of the new drugs for the treatment of cystic fibrosis, where the pricing, in our view, does not tie back to anything reasonable, and that what this would do is give the commissioner the ability to set a maximum price following consultation with the state's actuary, looking at data provided by the manufacturer, to allow the manufacturer the opportunity to justify the price that they're asking, and then the state would then have the ability to set that maximum price and basically require a rebate, such as is to ensure that the price, the net cost of the drug does not exceed the price ceiling. Once again, back to the concern from Assemblyman McDonald, this policy would not fall onto pharmacists. This would simply be a relationship between the state and the pharmaceutical manufacturer.
Is there concern that you said these drugs would have tremendous, benefits possibly? Is there a concern if you put these ceilings on the drugs that the manufacturers just won't provide them?
I mean, it's possible, but we believe we have the flexibility in how we administer the policy to make sure that doesn't happen. Basically, the way we see this is another sort of tool in the commissioner's tool belt when it comes to negotiating with manufacturers. Because as we've been looking at drug prices in healthcare, as I said previously, it's one of the major cost drivers in not only for Medicaid but nationally. We went through a period of time, say the last maybe up until about 1.5 years, 2 years ago, where we actually were in a situation where many of the sort of brand name blockbuster drugs of the past had come off patent. Things like Lipitor and Crestor, which are high volume drugs, were now becoming generic. Also happening in places like atypical antipsychotics, had moved in generic class, and now we've seen sort of a rebound in these drugs. And I think probably the best example would be some of the high cholesterol medications, which really are designed for individuals who can't tolerate the certain current mainline treatment for high cholesterol. The vast majority of people can tolerate and do tolerate very effectively drugs like Lipitor. But these drugs were designed for that subset of who can't. And they're priced very, very high. And the concern is that we want to make them available to who needs them, but we also want to make sure that the price we're getting from the manufacturers is appropriate, and that's what the proposal is all about.
But if it doesn't work out that way and the manufacturers decide not to provide them to Medicaid patients, aren't we limiting the access to these tremendous drugs to poor people when the people on private plans can still get them?
There is no mandate or requirement that the state do this. There's no requirement in terms of what that price is set. So the idea would be that the state gives the state leverage, but it isn't such a policy that it is so rigid that the state couldn't, if the manufacturer absolutely positively refused to supply the drug, that the state couldn't modify its approach. But what we can tell you is that when we have used our leverage in the past, that leverage has been effective. For instance, in the case of the hepatitis C medications, the introduction of a second drug into the market, while the drugs aren't totally interchangeable for all genotypes, they are for several of the very high volume genotypes. That kind of competition, that kind of the state ability to make certain drugs preferred over non-preferred has generated savings. And so I think at the end of the day, we have the potential to use this, as I said, just as another tool. But obviously, we do not want to use it in a way that would restrict access.
Do you? I know it's lumped in with the $65 million in savings. Do you have an idea of what this specific tool the savings could be?
Well, as you can see, that we did have a savings estimate. It looked particularly at some of the very high-cost drugs, drugs that we believe are priced inappropriately, drugs where if we had this tool, we could apply it. I think nationally, you're hearing more and more states, other payers beginning to raise concerns about these drug prices, wondering what the justification is. I mean, at the end of the day, really all we're asking the pharmaceutical manufacturers to do is to really provide information that supports their case as to why this drug is priced appropriately. At the end of the day, if the state determines based on the information provided it's priced appropriately, then we would agree to pay that price. But we have a suspicion that when that information is provided, that the state will make a different determination, and then that would lead to a much more robust discussion with that manufacturer about what that price should be.
This issue is going to grow in many ways because precision medicine and targeted drugs and pharmacogenomics is going to increase the number of medicines in the marketplace that are tailored to individuals, and I think this is something which is, as Jason mentioned, is not just a New York issue, it's a national issue, and everyone is looking at it right now.
Do you have an idea of how much there is in Medicaid fraud every year? How much the state loses to Medicaid fraud?
Well, you will, I believe today, I'm not sure if it's today, the testimony of the Office of the Medicaid Inspector General, usually they follow us. I'm sure that Mr. Rosen can give you a detailed description. I think that what you would see in our proposed budget is actually a new partnership between OMIG and our Medicaid managed care plans. Over the last 4 or 5 years with the move through Medicaid redesign, we've been moving more and more of our populations into managed care products. Billions of dollars in millions of individuals and their services moving into managed care. And we think at the end of the day that is a good strategy for preventing fraud, is that a lot of these companies have access to technology, they have access to resources above and beyond what any state agency might have that helps to prevent fraud. But that said, we always need to be cognizant of that as an issue. And so what this budget does propose is that a new partnership be established, plans be given actual targets for identifying fraud within their networks and sharing of information between the state agency and the plans and developing comprehensive plans. We think that will definitely help to address what fraud still remains.
Okay, thank you. Just to switch gears real quick, I was going to save this question for the acting superintendent of DFS, but I was told they're not coming. The excess medical malpractice fund, there's going to be changes to that. They're cutting $25 million from last year, and they're changing the way the risk assessment is done. Looks like there's going to be a ranking based on specialty and geography.
Right. So we looked at the excess medical malpractice, the excess liability pool, and we realized that we wanted to target this program to be more tailored to those who would benefit the most. And those who would benefit the most are those who are the high-risk specialties and in high-risk areas or potential places, potential individuals such as high-risk obstetrics. We surely don't want to end up with no high-risk OB doctors there. And this would move it away from those who are lower risk, who also need to have their malpractice coverage anyway. So we realized that this would be a better way to have the pool allocated, and that's why we're moving forward that way.
But based on the numbers that I have, it looks like under this proposal, 55% of physicians who currently receive coverage would be dropped from the program.
Well, the physicians who are low risk would not be part of the program, and it would be shifted to those that are high risk, as I mentioned. But those people who are low risk are already, they have malpractice coverage. They have to, as one who's practiced in New York, I'm aware of that. And we felt that would be a better way of doing this than basically having this distributed across all of those and add the 55% in where the amount would be so minimal.
I understand that going after, you want to help the high risk, but, there's a lot of underserved areas in the state from any, just family physicians. There's a lot of people that aren't served by them. So isn't there a concern that cutting the funding, $25 million, and doing this ranking system will cause doctors from upstate to leave where they are because they don't have access to this funding?
Well, it's not so much. I mean,
or this coverage. Sorry.
Right. When I say to areas, there could be a high-risk OB doctor in upstate New York, and that person would fall within that excess liability pool. I'm not saying there'd be one specific area of the state, and in many ways that would actually improve the situation because it would not have that physician who may be the only one in an area of 100, 200 miles to suddenly leave. And so I think that what we're doing is actually to the benefit of keeping the doctors who are high-risk doctors in areas that need to be to serve a lot of people.
Thank you. Thank you very much. We're up to 8 o'clock tonight.
Thank you very much.
Just one second. We've been joined by Assemblywoman Gunther and Assemblywoman Shelley. May I? Yes, Senator.
And Senator Kruger has an introduction.
Senator Velman Montgomery has also joined us.
Thank you very much. Our next speaker is Senator David Valesky.
Thank you, Madam Chair. Mr. Helderson, I just wanted to follow up on your answer to Senator Young's question in regard to There we go. Can you hear me? There, that's better. Question in regard to the disrupt timeline. I think you had indicated to her, you had used the phrase investing in infrastructure when you were talking about the transition between the district year 1 and preparing for year 2 and eventually into year 3. I have been receiving relatively frequent telephone calls from one of the hospitals in my district as it relates to the timeline for the distribution of capital grants. I think for the last 3 months or so, asking questions as to when those announcements were going to be made, what have we heard about those announcements. So can you just address the issue of the capital timeline? We're now 2 months away from the next district year, and I think there are a lot of questions out there that hospitals across the state have as to when those announcements are coming and why they have been delayed.
So, I'm happy to answer. This is the largest grant. This is the largest grant the Department of Health has put forth. It has over 700 applications that have been put out there. It's a competitive grant, a competitive process, and we are moving forward with this and want to make sure that this is done with the utmost caution. And so it will be soon, and that was why a little bit of a delay.
Would you anticipate the definition of soon being before the next fiscal year or after the start of the next year?
Well, we are moving forward quickly.
Okay.
We're moving forward quickly.
I want to just stay with the issue of capital. In the current fiscal year budget, as you both know, the governor had proposed and the legislature concurred with a $300 million capital allocation for a comprehensive health care facility in Oneida County. In this budget proposal, it appears that those dollars are being repurposed. $195 million capital fund for hospitals statewide, $5 million for purchase of mobile mammography vehicles as part of your breast cancer initiative, and $100 million for Nano Utica. Nano Utica is an important project for the Mohawk Valley. It promises to create a number of high-paying jobs, yet it has nothing to do with health care. So my question is, why the repurposing of this pot of capital money that was specific to Oneida County?
Sure. Thank you, Senator. I think the question of Oneida and the hospital there, the government is committed to this project. As the budget negotiations unfold, we will look at this and for allocation for that. This is a hospital. Oneida is, the hospitals there is strong. There is a strong system, and I recognize the need for where they're going. But I will say that as I said, the government is committed to this, and we would be happy to meet with the Mohawk Valley health professionals and to sit down and discuss this as we move forward, and it'll be part of the budget discussion.